I'm joined by both Dr. Elmer and Dr. Fichte. Dr. Endel was on his way, but he's still seeing patients. So 2 out of 3 is not bad. So he's still working. So the premise of tonight is it gives you the opportunity to speak to these 2 fine doctors, to ask questions about LASIK. How you can ask those questions is through the chat box on your screen. I will attempt to read those questions. If we have a lot of questions, you can always send questions to info@fichte.com. Now, for your attendance tonight, you are credited $50 off per eye if you decide to book refractive surgery. We can appreciate that. Also, you can request information at any time, an information packet from our refractive surgery coordinator, who will be happy to send it to you. So with that, I'm going to kind of look over the chat box and see if there's any questions that I can ask the doctors. We'll kind of take turns back and forth with each doc and ask them questions. I'm going to go out of the picture here for a second, just look at our box. And it looks like the first question is, nope, that's fine. I have I'll get my big fat head out.
I can read it.
Can you go ahead?
Yeah.
Dr. Elmer, go ahead. The first question.
All right.
Is dry eyes.
Okay, so first question, I have crazy dry eyes. Will it be okay to have LASIK? Okay, so this is a question that we get all the time. The question's about dry eyes. And so dry eyes is a very important thing, because the reason that's so important is the laser itself, when we cut some of the nerve endings, it can induce a little bit of dryness. So people often ask me, so what percentage of patients have dry eyes after laser surgery? And I say, oh, about 99%, everybody. Okay, so we plan on aggressively treating dry eyes after surgery, but for the vast majority of people, as the nerve endings grow back, that goes away and everything's fine. So for about the first month or so, we have used artificial tears a lot. Now, if you have dry eyes before surgery, we're going to want to treat that dry eyes before surgery. So people come to see us. It's very common, actually. You have dry eyes, so contacts aren't working. And our job is to treat the dry eyes actually before the surgery. So we will do that before, and we're going to treat the dry eyes. If for some reason the dry eyes are so bad that we can't treat it and you still have dry eyes, then we would not recommend laser surgery. Or we might consider just doing PRK, which is the laser surgery without making a flap. So yes, we see lots and lots of patients. If you live in Western New York in the winter, you're going to have dry eyes. Most patients do, actually. It's super common, and we will aggressively look for it and treat it. So typically we're doing tests for it. We're actually analyzing your tear film, putting special dyes in your eyes to look for it, asking you a lot of questions about it, looking under the microscope, and then we're going to treat it with artificial tears. There's these little plugs that we can put in the tear ducts that we use a lot. Sometimes taking oral supplements such as fish oils can be helpful. There's medications such as Restasis that can work. So yeah, that's our job as your eye care providers, to take care of you. And we were going to look for dryness. We're going to treat it and make sure it's good before we proceed.
We got a question that I think would be very well addressed by Dr. Fichte, because he's been doing this for a very long period of time. And we've done a number of folks from 18 years old all the way into their 60s, whatever. So the question was, the person wrote in and said, I'm 55 years old. Am I too old? Is it still worth having this done? So, Dr. Fichte, if you could just explain about age limits and whether it's worth it.
Right.
Please.
The eye is really a two-lens system. So when we're doing LASIK surgery or refractive surgery, we're working on the cornea, the outer lens. But inside our eye is our natural human lens, which is very flexible when we're young. And that's why when we're under the age of 40, that lens is so flexible. That's why people in that age group don't need bifocals or reading glasses. Okay, if they have their distance prescription in place, they're fine. They can read. They can see up close. They don't need bifocals. Or people who have excellent vision don't need reading glasses. Now, when we hit about age 45, that internal lens starts becoming more rigid. And so that's when people find they wake up one morning, their arms are too short. And so that's when people start doing this. And so that's when they start wearing bifocals or reading glasses. So now if you're age 55, you have to kind of make a decision. Yes, you can still have LASIK surgery, but it will only work for distance vision. Now, there's a caveat to that, and I'll get to that in a minute. But so pretty much, if someone is nearsighted and they want to have LASIK surgery and they're age 55, you'd be trading your distance glasses or contacts for reading glasses. Now, there's one way of getting around that is by doing something called monovision. some people do that with contacts. And monovision is where you take the dominant eye and correct that for distance vision, and you leave the nearsighted non-dominant eye alone, or you undertreat it so that the patient has near vision in the non-dominant eye. So let's say my left eye was my dominant eye. If I did this, then I would see a distance with my left eye, and my right eye would give me reading vision. Now that works very well for about half the population. In fact, I'm one of those people. Okay, and I've done monovision for probably 20 years now. And so, you know, monovision works great for me. I don't trip over the yellow line in the middle of the road. You know, I play tennis, I snowboard. I mean, I drive faster than I should admit because I stay trooper. But so that works. But the other half of the people are not comfortable with monovision. Their brain works differently. Maybe they're not as weird as I am. I don't know, but you know, so they are not comfortable with that. So monovision doesn't work for everyone. So before someone has monovision as a treatment option, then we really test that with them with contacts. So so again, but the bottom line is, if you're 55, you're really you're gonna trade your distance glasses for your reading glasses unless you do monovision. As people get a bit older, we actually solve that problem by working on the internal lens, which as we get more older, develops into what we call a cataract. That internal lens eventually starts getting a little hazy, a little cloudy, and then people in their 60s and 70s will get something called a cataract. And if that's removed and we replace that with an intraocular lens, that gives both distance and near vision. Some younger people get cataracts, and some younger people have, let's say 55, have such a strong prescription that they choose to have lens replacement surgery as opposed to LASIK surgery. But that's kind of, getting a little bit off, the common pathway.
Now, I know there's a lot of questions coming in. We'll try and keep our answers kind of short because a lot of you are trying to get in. But please, if there's not, that wasn't against Dr. Fichte, because I would listen to them all day, believe me. But the idea is, I don't want you to feel like we're ignoring your questions. These topics are always very interesting to us, as it is to you. So anytime if you have a question, info@fichte.com is always an avenue to reach us. We can send you information in the mail. We're happy to do so. We're also happy to see you in the office. There is a question I saw was just answered by our admin person who's actually answering questions about astigmatism. So that question comes up a lot, almost on every one of these webinars about astigmatism. But another question just was very interesting, just caught my eye from Dr. Elmer. A patient wrote, I had surgery 10 years ago on just one eye for reading, and now it's 10 years later and I have multiple pairs of glasses trying to help me out. What can be done now? So tell us a little bit about the change in technology from 10 years ago and what you might be able to offer to someone who now their eyes have changed.
It's a really great question. When Dr. Fichte first opened this office, and Kevin actually has been here from the beginning with us tonight, it was really, are you a candidate for LASIK? And that's it. And then when I came here about 10 years ago, we just started doing more general ophthalmology as well, and I'm fellowship trained in pediatrics. But things have really, really evolved in the time that I've been here and what we're able to do. In fact, about 5 years ago, we took out a sign that said astigmatism. We could treat that. It sounds like this terrible word, astigmatism. But yeah, we can absolutely treat it. But if you're any age group, you should really come in. If you think you want to be helped with your vision, we can help you. So if you're 55, you've had surgery before, things are changing, as Dr. Fichte was just mentioning. Things change as we age, the inside of the lens changes, and what we have available to us has changed tremendously in the past 10 years, certainly 15. So yes, if you come through the door, it used to be LASIK or no, thanks for coming, you're not a good candidate, but pretty much we have lots and lots of options for you, like Dr. Fichte was just mentioning, that we can do monovision, we can do lens replacement surgery, we have multiple lenses available, such as intraocular lenses can fix astigmatism, we have ones that can do both distance and near bifocal implants, we can make the eye that couldn't see up close see better up close now, we can do LASIK on one, lens replacement on the other. So really, that's sort of our niche, actually. The three MDs, what we've sort of grown our practice to be is you're going to come through the door and say, I would like to reduce my dependency in glasses. And it's our job as your doctors to tell you, okay, based on what your needs are, what your age is, what your lenses look like, what your prescription is, what are the sort of tools that we have in our toolbox in 2015 to help you out. And we got a pretty cool toolbox now. 2 of them sitting behind us right now, which are pretty neat. So we have a lot of ways to help people, and you really got to come in and see to answer the specific questions.
Well, one of the things that people really want to know about that I'd like Dr. Fichte to kind of talk about a little bit is the process by which we determine that you're a candidate. Talk about what the evaluation's like, what we do, how you get in here in 25,000 words or less. What brings you into the office and how do we process it?
People who have had this evaluation will say this is the most thorough, amazing evaluation they've ever had in their life. The reason for that is that we have to do, in order to see if you're a candidate for any kind of surgery, we have to do exam parts, components that are not part of a routine, thorough eye exam. So besides doing all the things that you would have done on a normal eye exam, we take these complicated measurements of the optics of the eye, much like if we were measuring the reflection of light from the stars. So we're actually using the same technology that's used in the NASA program to measure the optics of the eye. So we measure to see if there are any unusual features that go beyond just nearsightedness, astigmatism, farsightedness, and this then helps us determine if someone is suitable for a treatment. And we look at also pupil dynamics. One of the things that concern people are at nighttime, will my vision will I have glare, will I have halos? That used to be an issue with the treatment 15 years ago. That's essentially gone away, and the reason is that because of these types of measurements that we can do, and the treatment zones and parameters are so much better, we can really do a virtual treatment before we push the button on the laser to see whether we like what that treatment pattern is showing us. And then we go ahead. So it's added tremendously to the safety.
Well, to that end, we have a question that was just asked us personally. It was by actually our refractive surgery coordinator said, could you address what kinds of surgery? Now, people know about LASIK, they know about bladed LASIK, they know about no blade femto LASIK. Break it down, and what those things mean, Dr. And talk about the different surgeries.
Yeah, so Dr. Fichte was talking about it a little bit earlier, and I'm gonna grab a model real quick. That's part of the beauty of having a video going on. But basically, when we want to change your prescription, we could either change the cornea, which is a clear cap on the eye, which is missing at the moment from this eye, but there's a clear cap on the front of the eye that reflects light. So when we use our lasers, we're lasering the clear cap of the eye and changing the shape of it. Think of a magnifying glass. If you held it just right, you can burn a hole in a leaf. So our laser surgeries are that, and then the intraocular surgeries are really placing the lens on the inside of the eye, which isn't the easiest to see, but there's a little lens on the inside of the eye behind the iris. So our choices are, do we laser the surface of the eye, or do we replace the lens on the inside of the eye? And our society that we belong to is the American Society of Cataract and Refractive Surgery. So when you come to somebody that does just LASIK, you're going to have LASIK. And if you have somebody that didn't, like we started, the practice started, there was just LASIK here. But Dr. Fichte, of course, did cataract surgery, but not typically on purpose to change the prescription. But now we're often changing the lens on the inside. So that's the two basic things. And then when it comes to LASIK, there's really three basic things. One's called regular LASIK. It's a bladed procedure. We use a very precise mechanical device that has a blade that will make a slim flap of tissue and lift it over, laser, and put it back. And the reason we do that is so it's a very quick recovery, and it does excellent results. Kevin and I did some today. So we still do that. Then intra-LASIK is actually using a computer laser to make the flap. What Dr. Fichte was alluding to earlier, we literally can take a picture of your eye, it goes on the computer screen, we can look at it, everybody in the room, not just the surgeons looking at it, Kevin's looking at it, making sure it looks good, my other assistants, and actually the computer itself is telling us, giving us some feedback whether or not this is good. And then Dr. Fichte hates when I admit this, but I cross my arms like this and press the foot pedal and the computer does it. So very, very precise way of making a flap. It gives us some more options because some people's, the ways their corneas are, a blade just won't work. So some people that wouldn't be eligible for LASIK now can be because it's a computer laser making it. And then lastly, you can actually remove the skin layer on the surface of the eye and just polish that away with a Q-tip. The old term was PRK. We often call it advanced surface ablation now because it's really changed a lot the way we do it and how we control things these days and treat people preoperatively and postoperatively that have this surgery. It used to be considered kind of a painful procedure, but we've actually got it down where a lot of people have actually done PRK on one eye and LASIK on the other eye, and they feel no difference between the two eyes as far as pain. So we've actually done a huge advance in that area, and and we still do it probably about 20% of the time, I would say. So that's the other thing.
One thing that we should mention is that because of the type of measurements we take, we actually create a fingerprint of your vision. That's really what we call it. So that what we measure is unique to you as an individual, and it's different between your right eye and left eye, and it's different than your brother or sister. There are no two people on the planet that have the exact same optical fingerprint, and that's what we call a true custom treatment. It's exactly fit to you, and because of that, because of our ability to do that, now 85% of patients now have better night vision after their LASIK surgery than they did with their glasses or contacts. And that's huge, because when I started, we were just trying to tie the glasses, 20/20, like you had with your glasses. But now we can get better than that. It's more quality than just quantity. The other thing is that by using the laser to make the flap, we can add the precision and we can improve the optics. And so this is all part of what we call a custom treatment. It's not one size fits all. It's not optimized. It's like if you go into this store and you want to buy a 42 size jacket off the shelf, fine. That's a normal, bladed treatment. With a customized treatment, it's like you're having a tailor-made suit that fits you exactly for the rest of your life.
Just as a reminder, I'm just going to hold it up for a sec. This is an information packet that we do send. I don't mean to put it in front of the doctor's face, but the idea is info@fichte.com, or if you call the 1-800-309-2020 number and just let them know that you'd like to have some information sent to you via email or regular snail mail, we're happy to do so. And also as a reminder, for attending tonight, you do have a discount for refractive procedure if you do go forward with that. And also on the sidebar, you can also click on there and you can request an appointment for a consult. So you can come in and have the appointment. And reading through some of the questions that Casey, our person that's answering these questions, the biggest question that keeps coming up is, can you finance it? And how much does it cost? So Dr. Elmer, if you could talk about that and let us know the answer to those two questions. How much and can you finance it?
So yeah, the big questions: is it safe? Does it hurt? And how much does it hurt my pocketbook? So yeah, cost. It's funny. You would think the cost of these procedures are going down. They actually do. When the laser that we first started with is really sort of obsolete at this point, the technology keeps going up and up. So just like you could buy an old VHS tape player, but now it's all DVD or Blu-ray. So the technology is actually increased in cost over the years just because the technology and what it can do is increased. So to answer the question, it does vary, because if the technology can't be used for you, for example, if we do PRK because that's a better choice for you and aren't going to use this fancy machine to make a flap, it's less expensive. So the cost varies somewhere between $1,500 or so and about $2,000, a little over $2,000, $2,100 per eye is the cost of the laser. We have tons of options available. Kevin just handed me Care Credit, and it's just a financing option. We actually have interest-free financings for up to 2 years. So if you finance it, and there's lots of options out there for that.
So if we could talk a little bit about the difference between an evaluation and a screening. We know a screening means that they can come in at no charge. But talk about what's done in each one of those and why we favor one or the other.
Right.
Please.
Screening is just to see what is your prescription and quickly what are some of your corneal measurements to see if you're even a candidate for this procedure. Because we don't want to waste your time to spend, an hour and a half, 2 hours in our office going through a full evaluation. If the screening is a failure, then then no charge, and we apologize. But if a patient then wants to see whether they're actually a candidate for surgery, the evaluation is crucial, because it's not just the testing that we do, it's also getting to know you as an individual and see, what are you expecting from this surgery? Can we meet your expectations? And I always say, at the end of the evaluation, I like to be able to say to someone, you're a great candidate, you're a good candidate, if you're not as good a candidate as you would want to be, or as we want you to be, and you really should wait for technology to catch up to you. So that evaluation is crucial, because at the end of the day, our what we live by is do no harm. The last thing we want to do is not be able to help someone. This is a very happy specialty. We like getting hugs and thank yous.
Work for us.
So that's the best thing they can have to us. So the other thing is, we don't change, we don't bait and switch on prices. I mean, our prices are set, it's all inclusive. There's not like a charge, if you want this, you'll have to pay a little bit more, or you're not a candidate because your prescription's a little bit higher, or you have astigmatism, now you have to pay more. If you want the fancy lane, it's all inclusive. Right up front what is involved in paying for your care.
And that includes aftercare as well. Okay, so I mean, if you need treatment afterwards, or certain appointments we would expect you to come to just to make sure. We want to see you the day after, a week later, a month later. But if there's any other things that you need, that's all included.
I see Dr. Endel has joined us, so I'm going to direct a couple quick questions to him. We talked about a lot of things. One of the things that comes up a lot is, people want to, for now, somebody just called or just wrote in and said, can I drive myself home after the procedure? And I'm terrified of touching my eyes. So address both of those questions. Can I drive right after? And what about the fear factor?
Great. Well, the more you learn about the procedure, you find out that it's about 90% anticipation. And when you get through, it's really pretty simple, as you will find that, oh my goodness, I was there, I felt maybe a little bit of light touch for a period. They talked me through the whole part. Kevin keeps me calm with his witty repartee, and then we finish up. It is advised, as most people see, pretty underwater vision. You can tell there's already a correction, like opening your eyes in a swimming pool. You probably should not drive home from the procedure. We've had several sports coaches do that against our advice, and they did just fine. Having said that, we prefer you have a ride that day, and even a ride prepared for the next day, because we don't know what your vision is until we see you the next time. Now, as far as you're a bit afraid to touch your eyes, well, good, because we don't want you to rub your eyes for a couple of days. If you can touch your cheek and put your face up in the air, you can take drops. Even if your eyes closed, when it opens, the drop will fall in. The many thousand times we've done this, we'll talk you through it. We'll get you through the drops, which are just for a few weeks. Very simple.
Dr. Fichte, this patient wants to know, does diabetes affect having laser eye correction?
Most of the time, diabetes has no effect on having laser eye correction. The important thing is that the diabetes is stable. We don't want someone whose blood sugar is extremely elevated, and it's important that they don't have any changes inside their eye that would put them at risk. But 90% of patients with diabetes, there's really no problem whatsoever. But that's the important part of the evaluation, so we can determine, are you a diabetic that is appropriate for this procedure, or we have to get your diabetes in control, or you have some advanced changes that would really preclude you from doing something that's elective. Again, it's safety first.
Now, we've heard of some centers that offer what's called a free evaluation. You exam to come in and have your eyes checked. Now, we don't do that here. We actually have you come in for what we call an evaluation. There is a charge associated with that. Dr. Elmer, explain why and what the charge is and why it's so important that you have a very thorough exam. We talked about a little bit before, but basically, what's the cost of the evaluation?
Okay, so the cost of the evaluation is $150 up front, but really it's free because I think of all the patients that have evaluations, it's about 97% go on to have surgery or something along those lines, 90%, 95%. So that fee comes right off the cost of the procedure. So if you go on to have surgery, we'll take that off. The reason we charge it, it actually doesn't come anywhere close to covering our cost of doing the exam. Like Dr. Fichte mentioned, it's about a 2-hour exam. We run you through all these computers that are now available to us to evaluate you and get the exact fingerprint of your eye and do computer analysis of your eye to make sure it's safe. So it's a very, very thorough exam. So we spend a lot of time on it, and we do have free screening. So if you want to come in and see if we think you're going to be a candidate, we'll of course do that. There's no charge for that. But if we're going to do the full exam, we just want to make sure you're committed a little bit to do that and help just offset the cost of it for us a little bit. And once again, we'll take it right off. But for example, if you came in and you didn't even know you were diabetic, and we found that you had damage in your eye from diabetes, and we decided at that point you weren't a candidate for diabetes, what we usually do is we flip you to a regular exam and then treat you for your diabetes before. So we would take care of you still. And then, of course, that being a diabetic would usually go through your insurance. So then you wouldn't be charged that fee.
We're kind of running down to the last few minutes, but I know a very important question I'd like Dr. Reynolds to ask, or answer, I'm sorry, is what about prior to your evaluation, contact lens wear, and why it's so important that your contact lenses are not in right up to the moment that we check your eyes. Would you please talk about that, please?
Sure. I think my partners had talked about this optical fingerprint, where the more we get the exact curvature shape, unique shape to your eye, the better quality we can give to you. So not just your glasses prescription, which many lasers can do, but we have the 2 customized lasers approved by the FDA, which in our national meetings, there's almost no argument that gives you the best chance at the safest way to your best vision, less glare and halos, not just good daytime vision, but good nighttime vision as well. Well, the best way to get that is know your true shape, not your slightly warped shape from overwearing the contacts. So we really prefer contacts are out for 2 weeks beforehand. If they're a soft lens and you don't wear all the time, a week may be okay, but some of our maps at your 2-hour evaluation may show us that, well, it's a pretty good picture, but it looks like they've still worn the contacts too much, so we'll know if you're cheating a little bit too. But we want to be most accurate. And again, we joke, but you're not cheating us, you'd be cheating you. The laser is wonderfully accurate at treating what it measured, but you want it to measure your true shape, not your slightly warped shape. So important to stay out of that for a couple of weeks. Now, once we get all those good measurements, some people choose to have surgery a day or 2 after their evaluation. Some people not for a couple of weeks, depending on their schedule. After your evaluation, if we have talked to the doctors, and usually see 2 different doctors have evaluated your information, we'll make sure that we're happy with it. Then you can actually wear the contacts again as needed up until your surgery, at least till the day before. So it's just a period before so we can get good quality measurements. So the rest of your life, your distance vision will be very nice.
Well, as promised, we try to keep these right to about 30 minutes. We're around 29 and a half. But we don't want you to feel like we're rushing you or you can't get your questions answered. You had some questions I saw that wanted to know about the side effects of this, about halo and glare, about a lot of things that a lot of people ask. So what I would ask you all is if you have more questions, info@fichte.com. You can always call the 800 number and talk to our refractive surgery coordinator, who's Erin. She's always happy to answer questions for you. We're always available. We do have open houses once a month where you actually can come into the office and watch a live procedure. So in conclusion for tonight, we'll have another one of these soon. But if you need anything, please don't hesitate to contact us. Thanks for joining us tonight.
Thank you.
Thank you very much. Good night. Thanks.